Hello, everyone. Good evening, good afternoon, and good morning to all over the world from the doctors. And welcome to the RWD Vet Academy channel. And thank you for your attention. My name is Belle Du, as the sales representative in RWD for the Middle East and Asia Pacific, like Thailand. First, let me introduce our company briefly. RWD is a life science company focusing on the animal health. On the more than 20 years history, we try our best to provide a comprehensive service in anesthesia management and ventilation in practice, dental health and recovery option. Looking up to the spread knowledge from experienced doctor, we launched this channel for medical technical communication. For tonight's topic is sedation and anesthesia in animals with airways problems. Sedation and anesthesia of brachycephalic dogs is a challenge veterinary surgeons have to face with increased frequency. This talk will discuss the anatomical and physiological features of brachy dogs and how these practically affect anesthetic management. Based on our current medical knowledge and the experience of the speaker, a better understanding is the first step towards improving outcomes. Professor Federico is our today's he will share on this topic. He has specialized in veterinary anesthesia for more than 20 years. He's a board certificate specialist in anesthesia and anaesthesia by the Royal College of Veterinary Surgeons and the European College of Veterinary Anesthesia and Anaesthesia. Now he is a professor at the University of Nottingham. If you have any question during the class, and you can type on through the Q&A function after the class, and the Professor Federico will answer them after the class. Now let's welcome our Professor Federico. Welcome.
Thank you very much, Belle. Good morning, good afternoon, and good evening, everybody. As you said, now I try to share my screen and hopefully it's going to work as it did before. And now, of course, it doesn't work now. Of course, it doesn't work. What's happened here? Why is it not working? Stop sharing. I try to share again. That's better. Can you see now? Yeah. Is it okay? Absolutely. Belle?
Okay. We can see the screen.
Better. That's better. Sorry, I just wanted to make sure. So, as introduced by Belle, we will discuss sedation and anesthesia in animals with airway problems, particularly focusing on brachycephaloobstructive airway syndrome. I mean, these two CT scans show the remarkable difference between a normal dog on the left and a brachycephalic breed with all the aberrant anatomical features of the second one. And there are different reasons why we see animals with airway problem. More and more commonly, we see brachycephalic dogs presenting for elective surgery for correction airway problem, but we also see elective surgery of laryngeal paralysis or animal presented with tracheal collapse for elective correction stenting. We also see emergency surgery for airway problem, and those in particular for the brachycephaloobstructive airway syndrome and laryngeal collapse. What is important in these animals is to gather an intravenous access at early stages. The sooner the better, because as we will see later, they can decompensate very quickly and the disease can progress very rapidly. In my experience, a good way to secure the IV access is to use midline catheters, so peripheral catheters, but a bit longer and softer. They're introduced with Seldinger technique and they can be sutured to the skin. And this one can stay in situ for days or weeks. In human, they're designed for chemotherapy, so they can stay in situ for up to a month. And they are very difficult to dislodge and they are not thrombogenic. Now, what we do if the animal presents cyanotic, but obviously the first thing that comes intuitive to do is to administer oxygen. There are different ways to administer oxygen to this animal. The face mask may not be well tolerated because this animal are in respiratory distress. In that case, a good alternative is a flow by oxygen, just with 2-3 liters per minute of oxygen in proximity of the nose and the mouth. Though some authors reported their personal experience using a CPAP helmet with non-invasive ventilation to settle this animal. In my experience, if they are respiratory distress, it's quite difficult to get them to sit inside the CPAP helmet, which gets all steamy and humid and is quite loud noise. It works much better when they're not in the acute crisis. When we assess this cyanotic animal, is crucial to identify the possible reasons of the problem. And the good way to do it is just to listen to this animal. Because by listening, as we will say in a second, we can pretty much rule out if the obstruction is happening above the larynx, in which case anesthesia induction and intubation are the treatment of choice to resolve the problem, at least until we correct it surgically. Or if the obstruction is at the level of the larynx, pharynx, or below this level, in which case intubation may be difficult, if not impossible. And if I suspect a severe laryngeal obstruction, I would definitely get ready for a tracheotomy, possibility of a tracheotomy immediately after induction of anesthesia. Finally, we need to rule out compromission of gas exchange, so with a genuine lung pathology, which sometimes happens in this animal because of aspiration of gastric content or coexisting pneumonia. Now, the big question when we listen to this animal, if this animal is presenting a stertor or a stridor. The stertor is a typical snoring noise, and this is a low-pitched noise, and it's caused by tissue flapping with a movement of air like a flag. And this is pretty much indicative of upper airways problem. Most of the time, it's a soft palate flapping, creating the typical snoring noise. On the other hand, stridor is the high-pitch sound that's caused where an airway is critically narrowing and the air is accelerated, creating the typical wheezing noise. It can be biphasic, inspiratory, respiratory, and there are, in terms of location, you can generate stridor at the level of the nostril. Think when you got a bit cold and you make the kind of high-pitched noise when you breathe in and out, or from the larynx down. It's fairly easy to tell if it's coming from the nostril, just examining the animal and listening to the animal, or we can put a stethoscope on the larynx to determine if the origin is at the larynx. A laryngeal stridor is certainly a worse prognostic indicator. It indicates a critical situation that may lead the animal to decompensate very quickly. If we look in detail at brachycephalic obstructive airway syndrome, but all these principles actually apply to pretty much every animal with airway problem. Specifically in brachycephaly, we have some anatomical problem that cause the cause of the clinical signs. So we've got very small nostrils. We may have a kind of a malformation of the nasopharynx, the soft palate and the turbinates may be very cramped, decompressed turbinates. The soft palate may be thick and long. We can have laryngeal soft tissue edema because of negative pressure, because of the inspiratory effort, but also because many of these animals present gastroesophageal reflux. So the acid is causing irritation of the upper airways. And because of this negative pressure, we may have eversion laryngeal sacals. And most of these animals will also present a variable degree of hypoplastic trachea, which tend to be more accentuated, more evident in some dog breeds than others. For example, British bulldogs tend to have a severely hypoplastic trachea, which complicates quite significantly management of the cases. If we look in detail at what's happening in these airways, essentially, we have an increase in resistance to breathing. And we know that if you halve the radius of an airway, resistance increases 4 times. So it's increased to the is a square relationship. It's directly related to the length, and it is inversely related to viscosity of the gas, which we could do something, but we can't really do much at the moment. The increasing resistance, of course, will cause the animal to breathe harder and will generate a bigger pressure difference from the outside to the inside. So the muscle will work harder. This will cause more heat production and exhaust the muscle. And because of the massive negative gradient, pressure gradient, they tend to collapse the airways below the obstruction. Eventually, we will see decrease of alveolar ventilation because the animal can't breathe properly. This will cause hypercapnia, and the hypercapnia will make the animal breathe faster. And this will further increase the pressure gradient. The muscle will work very harder, and eventually we trigger a vicious cycle, a spirals that you see at the right, that if we don't stop it, will lead to the death of the animal by exhaustion or by complete obstruction of the upper airways and global hypoxemia. What is important to stress is that these animals can deteriorate very quickly. This applies for brachycephalic dogs. It applies to laryngeal problems in dogs and cats. In cats and small dogs is even worse because the airways are already very small. And this rapid deterioration is causes considerable stress in the animal. This stress will release cortisol and catecholamines and will increase cardiac work under a condition of oxygen debt. So it's like driving your car with a handbrake pull and keeping pushing to get more gas. You're going to burn the engine. And that's what's going to eventually happen in this animal. They compensate, they struggle to breathe, and all of a sudden they crash. And when they crash, they're very difficult to get back because they crash because of global exhaustion. It looks sudden, but this is an event that starts building up even hours before the crash itself. It's just the rapid deterioration that we see. We just see the last event, but there is a long story before that. If we can stop it earlier, we can actually prevent the problem. These respiratory issue and cardiovascular problem will also cause acid-base imbalance. Initially, this animal can have a significantly hypercapnia with respiratory acidosis, which trigger cortisol and catecholamine release, but eventually, because they're hypoxemic, they become hypothermic, they will develop significant metabolic derangement. So you can have respiratory and metabolic acidosis. I've seen hypothermic, hypercapnic bulldogs with a pH of 6.8, which is essentially impossible to survive. And this SUT was a three-figure, 110, 120. So just because of the compensation happened so quickly. What we have to do, we have to stop this sequence. And just to remember, we can actually use a stop as a little mnemonic. Well, the S is for sedation, and we will see in detail sedation, because sedation will decrease airflow and therefore the pressure gradient. Think about breathing through a very narrow tube. If you try to suck it really hard to breathe in, you really struggle. But if you breathe calmly and slowly, you can actually move some air. So we want this animal to resist the temptation of panicking and trying to breathe really hard, because that's going to make it even worse. T is for temperature. We need to make sure that the animal is not hot, and cool it if needed, because it works so hard. It's like exercising very hard, the respiratory muscle, and then we actually cause hypothermia. O is for oxygen, of course, because we need to improve reserve of oxygen to meet the increased metabolic demand. And the last P, I think, actually could be for paralysis. In some cases, these animals are so difficult to manage that you might need to give a neuromuscular blocking agent to completely paralyze every muscle in the body, so you can actually take control of ventilation and rest the muscle. This is necessary because even after you intubate them, you can't ventilate them because they keep pumping so hard, just because they are so badly hypercapnic, so badly hypothermic, that you can't break this vicious cycle, and you may need to paralyze them. Sometimes, very often, actually, when you reach the P point, especially, so you try sedation, you try temperature, you tried oxygen, it doesn't work, you will need to anesthetize this animal to gather control of the airways, to solve the obstruction, and also to try to control ventilation and rest the muscles. What you need to remember, in this animal, endotracheal intubation will be difficult. Let it be a brachycephalic dog, let it be laryngeal collapse, or laryngeal mass, or laryngeal edema, intubation will be difficult. So you may struggle to find the laryngeal opening. So I would suggest you to use a rigid dog urinary catheter inside the endotracheal tubes, sticking out, poking out a few centimeters. You get the tip of the catheter inside the trachea, and then you slide the catheter. So this is a bougie. It's not a stilette. A stilette is a metal implement to change the curvature of the tube. You need to watch out because the stilette can actually damage the mucosa. It should never poke out of the tube. The plastic softer rigid urinary catheter actually doesn't traumatize easily the airways. And of course, you need suction to be ready because they will have hypersalivation, lot of secretion. They may have a regurgitation. They may have reflux. What is important, and this is where actually most people fail, this is a one-way road. You need to intubate this animal. You need to be committed to do it. Some people think that, well, I give a tiny bit of anesthetic, so if I can't intubate, it's going to recover. Unfortunately, it doesn't work like that. If a light anesthetic will cause obstruction, but will not allow the endotracheal intubation because the animal will keep swallowing and moving. So you need to hit the animal with appropriate amount of anesthetic, stop ventilation, relax the airways. But that means that if you can't intubate it, you need to be ready to do a tracheotomy very, very quickly. A problem is it for a laryngeal paralysis and collapse. If you want to assess function, you may have to try to balance the two because you want to have a light anesthetic to assess function and then get deeper to intubate. But what is important, once you try to intubate, make sure you put yourself in the best possible condition for intubation. That means the dog properly or a cat properly anesthetized. When we talk about what we need to manage, I say before we need to stop this animal panting and breathing too fast because that respiratory pattern is not affecting gas exchange, it's generating heat, is increasing work of the muscles and using oxygen and increase the temperature. Opioids are not always effective in this animal to stop panting. As you know, if you give it to an awake animal, they actually may trigger panting. And they may not be effective also because the animal may be hyperventilated because of an hypoxic drive, and opioids tend to suppress the hypercapnic drive. Also, there is a link we will discuss in the next couple of slides, is about administration of opioid perioperatively and increased risk of postoperative regurgitation and aspiration in animal with airway problem. If you overdose the anesthetic to stop this animal panting, that actually may work for a short time, but you may cause unacceptable cardiovascular depression. So you may try once to cause mild cardiovascular depression, to control ventilation, so a little problem for a much better long-term outcome. But you can't keep overdosing anesthetic consistently because then you will have an hypotensive, hypoxic, hypercapnic animal, which is not a nice combination because it's also hypothermic. You need to address temperature. So now cooling them down actively, that means you can give fluids that cool temperature. If they're very hot, you can use a bladder lavage with cool saline. You can use ice pack in the armpits and the groin. You can wet the body and use a fan on it. Don't use wet towel because they're actually going to warm up the animal. So just wet it, but don't use wet towel on top of the animal. In extreme cases, I have to resort to use non-depolarizing muscle relaxant, so to paralyze the animal. This is the only way that you can actually completely rest the muscle. It's very easy to control ventilation. The problem is you need to make sure the animal fully recovered before you wake them up. So you need neuromuscular blocking agent monitoring and possibility of reversal. The last thing you want is to wake an animal with questionable airways that's got residual paralysis because they won't be able to keep the airways painted. And once we anesthetize this animal, how long do we keep it anesthetized before trying to wake them up? Well, my suggestion would be to keep it anesthetized until they are normothermic, until they settle, and the acid base and electrolyte balance is back to normal, which means probably 2 to 3 hours to normalize temperature and acid base electrolyte balance before trying to wake them up. Now, back to the opioid. Some of you may have seen this kind of seminal paper, which is very popular with surgeons. And this was looking at risk factor for developing respiration pneumonia after unilateral lateralization of the arytenoid in dogs. And one thing they found is actually postoperative opioids were nearly increased twice the risk of aspiration pneumonia. They were not as bad megaesophagus, but it is quite significant. I think about if you combine opioid with megaesophagus, and then what could be the result. And if you talk about BOAS, you will not have megaesophagus, but you will have hiatal hernia, very common in these animals. So this is something that always puzzled me. And just very, very recently, this is actually 1 month, no, not even 1 month ago, I stumbled in this paper, which is an investigation in cats where they just give buprenorphine, which theoretically is the safest opioid for affecting the airways and the swallowing and causing nausea and vomiting. They give a 20 microgram per kilo dose and a 40 microgram per kilo dose, and they actually assess the effect on esophageal motility and a bolus of a thin puree or a lower higher doses of opioids. And they got a score about safety. And if you end up in the red area, the animal is by big risk of aspiration, as you can see. Well, what they found is that if you give buprenorphine, even a very low dose, you got increased esophageal distension before peristalsis. And the peristalsis, the time to push down the bolus, lasts actually longer, significantly longer. And there is pretty much a plateau effect of 20 microgram per kilo. So you got maximum negative effect on the duration of the phase, of the pharyngeal phase. And if you look in terms of safety, once you give the lower dose, you just increase a tiny bit the risk of pneumonia because affecting the swallowing mechanism. But if you go up to 40 microgram per kilo, the risk becomes significant. And the conclusion is that there is a decline in swallow function following opioids, and this is buprenorphine, remember, one of the safest one. And this is due to central disturbance of the swallow muscle pattern and depression of aerodigestive sensation and protective reflexes. So this is something you might want to remember in this animal, that these do not give too much opioids. Avoid, if possible, resort to other alternative for analgesia, as we will see later. So let's discuss about sedation now. I told you the purpose of sedation is to calm the animal and decrease the circulating catecholamine. So rest down everything, cause hemodynamic stability, restore blood pressure in the normal range, restore heart rate in the normal range, allow dropping of temperature, allow easier breathing, better oxygenation. And sedation will improve gas flow if it does not cause respiratory depression. So you need to watch out. If we give something that causes respiratory depression, we might actually cause problem. And also, sedation should not really cause relaxation of the soft tissue in the upper airways because it may worsen obstruction and may promote aspiration. So what can we use for sedate this animal? And now you see the picture of that lady. That lady is nothing to do with anesthesia, it's a dermatologist. That lady is Janet Dr. Littlewood. She was a dermatologist when I was doing my residency at the Animal Trust 25 years ago. And I was told as a good resident at the time, you stay away with alpha-2 agonists from brachycephalic breed because they crash. And they never used it. Then I saw Dr. Littlewood sedated this animal for intradermal skin tests with large doses of medetomidine alone because they didn't want to use butorphanol, and they did not obstruct. And I started thinking, hang on a second, something is not right here. Either she's very lucky or I'm missing something. We are making an assumption about this drug, but it's actually not the case. So over the year, I started using more and more, experimenting with alpha-2 agonists, but I was trying to look at evidence for it, and I actually found it in humans eventually. And in humans, there are two essentially fairly good situations where the airways are critical. And one is obstructive sleep apnea. So it's very similar to the brachycephalic syndrome. It's got similarities like thick, elongated soft palate, collapse of the upper airways, which cause full obstruction. And when you want to do imaging studies in children with obstructive sleep apnea, it's very tricky because you give a little dose of propofol and they end up like Michael Jackson. They die. They may die. You need to resuscitate them. You give benzodiazepam and they obstruct. So they start using dexmedetomidine, and they found that this dexmedetomidine was providing a good level of analgesia and sedation, for the MRI in children with obstructive sleep apnea, with much better airway than any other drug. So they were not obstructing as frequently. And this is a study in in a worst case scenario, which is children with Down syndrome with obstructive sleep apnea. And the Down syndrome has got some similarities, similar feature to the brachycephalic obstructive syndrome, because it's got stenotic nostrils, cramped turbinates, hypoplastic trachea, thick elongated soft palate, redundant soft tissue, thick tongue. So these children are very difficult to sedate. And they actually studied the effect of dexmedetomidine, and they found that the upper airway reflex is actually well preserved during dexmedetomidine sedation in these patients. And they say that essentially the airway response with dexmedetomidine is parallel to that seen during natural sleep. So if they start obstructing, they tend to clear the airways, like when you're asleep and you snore and you stop breathing, yeah, then you take a deep breath and up you go again. If you achieve this level of sedation without benzodiazepine or other drugs or propofol, the obstruction actually becomes life-threatening. This is actually a propofol sedation in adults with apnea and hypopnea, so quite significant. And again, they found that dexmedetomidine sedation was associated with a lower incidence of upper airway obstruction than propofol sedation in these adults with mild obstructive sleep apnea. So there is a ground for using alpha-2 agonist in this animal. And if you look at brachycephalic breeds, these are actually quite sensitive to this drug. So my choice, if I have to sedate them just before anesthesia, is to give 1 microgram per kilo dexmedetomidine with a tiny bit of butorphanol. Question is a full opioid agonist required? If they need to have both surgery, I can get away doing a maxillary nerve block, and I'm going to anesthetize the palate, soft palate, hard palate, nostrils. And if they do the succulectomy, it's not particularly painful. So my first choice in this animal for surgery is to do a maxillary nerve block, either placing a cannula and sliding into the infraorbital canal, or using an intraoral approach closer to the last molar. And I tend to use lidocaine with adrenaline 1 in 200,000 because in a study that was run where I was working before, it was quite nicely demonstrated that they actually tend to decrease bleeding during surgery, because if you deposit the adrenaline closer to the last in the pterygopalatine fossa, is in proximity of the maxillary artery. So at this concentration, because a bit of constriction of the artery, I tend to decrease bleeding. I tried with the higher concentration of adrenaline, and I actually got a problem with the animal experiencing pain postoperatively, and I suspect it's because of arterial vasospasm. It's like when you get something very, very cold, you're eating a very cold ice cream and you got sharp pain in your sinuses. These animals behave exactly the same way. They just go really aggressively for their face sometime as soon as they recover, then they settle. So I would suggest using 1 to 200,000 as lidocaine. If you need to sedate these animals to do investigation under sedation, for example, here we tend to do CT under sedation in brachycephalic breeds to study the airways, you can increase the dose. And they generally tolerate fairly significant doses of dexmedetomidine very, very well. And if IV access is not possible, I'm pretty happy to sedate this animal with 5-7 microgram per kilo dexmedetomidine and some butorphanol intramuscular. Sometimes I push the dose even higher if the animal is particularly excited, and I actually never had a significant issue with collapse of the airways with this sedation. You eventually get in recovery after surgery, but not with the sedation. But you always need to be careful there. So why is it necessary to induce anesthesia sometime? Well, it's a poor response to sedation and oxygen therapy is the main reason. And when the airway obstruction is nearly complete, or where you got severe hypothermia and muscle fatigue with the spirals that's going to eventually lead to the demise of the animal, you can't stop it. Of course, if you need surgery. When you use anesthesia, you need a rapid control of the airways. You can use propofol or alfaxalone. That would be my 2 top choices. If you got thiopentol, you can use thiopentol. I wouldn't use ketamine because it doesn't suppress reflexes that much. You can use some topical lidocaine spray to facilitate intubation, though these animals tend to have quite low sensitivity in the upper airways. But important, remember what I said before, light anesthesia does not allow intubation, but will cause airway obstruction. So you need a proper anesthetic depth to intubate this animal. Get suction there ready, and use a laryngoscope. Never try to intubate this one blind because there are lots of soft tissue. You need to visualize the larynx, and you are not allowed 2 attempts because if you get it wrong, it's going to turn blue. And use a rigid dog urinary catheter as a bougie to dry the tube inside the trachea. And get ready for the worst. You can have a 30-kilo bulldog that requires a 4.5 millimeter tube, or you can have a French bulldog that can take a 5.5 or 6 millimeter tube and is 12 kilo. So I generally prepare anything for 4 to 7, 8 and long tubes, because you never know we're going to find. And also remember that the tongue is going to be wet and slippery in saliva, so use a swab to try to get yourself in the best possible position to intubate the animal. For maintenance of anesthesia, there is actually no specific requirement other than oxygenating this animal and controlling the hypercapnia and the temperature and maintaining hemodynamics. So you probably look at the morbidities. If they got other problem, you look after those other problem. It may be necessary to cool the animal if necessary. So you can use higher gas flow rate, fluids, you can have external cooling, but just be careful. Do not wake up this animal hypothermic, because if they are hypothermic, they will start shivering really hard in recovery, and shivering compromise ventilation and increase oxygen consumption, and these will actually be detrimental in this animal. If a panting persists under anesthesia, when anesthesia is also quite deep, I would again consider muscle relaxation or neuromuscular blocking agent, but you need to monitor the neuromuscular block. So you need to have a trainer form monitor. Intermittent positive pressure ventilation is a must in this animal because you need to control respiratory acidosis. You want to rest the muscles, essentially, and you want to recover quick and complete if possible. Going back to IPPV, because of the pathophysiology of brachycephalic obstructive airways syndrome, and the phenotype of this animal, they tend to be barrel-chested, overweight, and they get exhausted. They arrive exhausted with inefficient ventilation. Sometimes they got aerophagia, so they got a distended stomach, or they got gastric paresis, so they got a stomach full of fluid and food. You need to use intermittent positive pressure ventilation, pretty much from induction of anesthesia throughout. And even during elective procedures, sometimes, as I say, spontaneous ventilation is not always adequate because of their conformation. If you ventilate them because of their conformation, they may need higher peak inspiratory pressure. It's not uncommon to ventilate this animal between 15 and 20 centimeters of water. And always remember the effect of the body shape and the narrow airways and the muscle tone. So you need adequate anesthesia. And as I said before, in some cases, you might have to resort to neuromuscular blocking and paralyze the animal. You generally need a lower tire volume compared to other dog breeds. So usually between 7 and 12 ml per kilo, while most dogs will take 10 to 15, 16 ml per kilo. And you'll be able to increase the respiratory rate to guarantee gas exchange. Sometimes an initial deep manual breath with a bag may help recruit alveolar units that are closed, and it may also inhibit for a tiny bit spontaneous ventilation stimulating stretch response. So that would be my first intervention. If I put the animal on the ventilator and he keep fighting the ventilator, I switch the ventilator off and I give a few very deep breath, quite significant pressure, even 20, 25, 30 centimeters of water, holding it, try to lower the CO2. And so the animal is fighting the ventilator, but I fight the animal more than the ventilator. I lower the CO2 and I stimulate stretch receptor to induce apnea, and then I switch on the ventilator immediately and see if he stays on the ventilator. Most of the time, this actually works. You might want to consider using some positive end respiratory pressure because these lungs tend to collapse because of this diaphragmatic splinting and the pressure of the abdominal compartment. And very important, remember that if you got a rapid shallow breath or with a low tidal volume, your capnography reading may not be correct. So you might be ventilating this animal and struggle to ventilate this animal with a CO2 at 25, 30. You say, why is he panting? Because the CO2 is so low. Then you try to give a couple of deep breaths and your CO2 is actually 90. It's just because the animal is shallow breathing and it doesn't bring the alveolar gas to the mouth. So if you got an animal panting with low CO2 and you want to know the real CO2, give a few deep manual breaths, 3, 4. That may also help in stopping panting, but you will get the real capnography reading. Achieving normocapnia or an acceptable level of hypercapnia may be a lengthy process, as I said before, because these animals are producing a lot of CO2 because they can be hyperthermic and the muscles are working hard. It's not just hyperventilation. And as I told you before, I've seen a few cases with 3-figure entirely CO2, so above 100, when it actually becomes a narcotic gas, and at that high level, it would actually cause alveolar hypoxia. And management ventilation is also, remember, is affected by comorbidities in this animal. So doing a chest X-ray, or better even, a CT as soon as possible to have a rough idea if there is aspiration pneumonia, is quite good. And remember that sometimes you got this animal that present a 6, 7, 8 in the compensated, and that brachycephalic syndrome is actually not got worse, but they got pneumonia on top of the brachycephalic syndrome, and this is actually precipitating the signs. As I said before, you may need high peak pressure with some PEEP and lower tidal volume with some recruiter maneuver where you forcefully inflate the lung and you keep the pressure for 25 or 30 seconds. And most of these animals will require oxygen post-operatively when they are extubated. What you need to do, you need to look at the conformation, you need to look inside the airways, inside the oral cavity, the larynx, and sorry, identify animal greater risk, and you need to monitor those animals very closely because those are the animals where we deteriorate very, very quickly. In terms of monitoring, there are, again, no specific consideration. You need to consider comorbidities, but I would say this animal, you need for sure an electrocardiogram. Most of the time, non-invasive blood pressure is fine unless you got cardiovascular disease coexisting. Pulse oximetry, temperature, and capnograph. Arterial line for blood gas actually may not be that bad idea, especially if you got lower airway disease concomitant, so pneumonia, for example, because you may be difficult to tell is the animal dyspnea because of the upper airways, the lower airways, a combination of the two. And you can look at oxygenation and exchange of CO2. If you use the neuromuscular blocking agent like atracurium, rocuronium, becuronium, please use a monitor because you need to be sure that animal is fully recovered before considering waking it up from anesthesia. Fluid therapy and support. Most of these animals will have some relative absolute hypovolemia, and that's because they are hypercapnic, so they're vasodilated, and also because they become dehydrated, because they are hot and they pant. So you need to address volume replacement, looking at electrolytes and acid-base disorders. Remember, you got a predominant respiratory acidosis, which can make very difficult interpretation of blood gas. But generally, using a balanced solution, electrolytic, like Hartmann's Ringer, at least twice maintenance as a baseline, and then bolusing 2-3 ml per kilo as needed is a good start. What you want to avoid doing is overload this animal because this may promote edema, not just lung edema, but just edema in the airways. Just because they are inflamed, so there is increased permeability because of inflammation. So when you push a lot of crystalloids, they will actually tend to leak out significantly in the submucosa tissue. Recovery is probably the most difficult time, and there is a risk of obstruction if the problem is not being properly corrected, or it can't be corrected because it's beyond correction level, for example, a severely hypoplastic trachea. But there is also risk of obstruction because if you correct this problem surgically, there is some soft tissue edema after surgery. You can use steroids like dexamethasone before inducing or just after induction of anesthesia because it's one of the most powerful antidiuretic drug we have. Or you can use, I think this one's quite nice. Take some swab with saline, put them into the freezer and until they're solid. Then you take them out, you start throwing them a tiny bit until they're no longer sticky. And you just put them into the oral cavity, of course, tie them with a string. And you keep them like inside the mouth. It's like they do in children and with the tonsillectomy, they give them to suck ice cream, ice lolly, because it's cold and cold is going to soothe pain and it's going to reduce edema. The other thing you can try to do, I've seen done, you fill a glove with water, you put into the freezer. So you stick the fingers inside the mouth with the frozen water inside, so it doesn't stick to the mucosa causing damage, and it's gonna have the effect of an ice pack. Recovery should be quick and complete. You may give some sedation to help keep the tube in place longer, but remember that these animals actually tend to tolerate endotracheal tubes until they're fully awake. I've seen some of these animals walking with the endotracheal tube in place. They're just not particularly bothered about it, especially if you put the block, they're going to feel the tube even less. As I said before, airway obstruction is the major concern for recovery. And what do you do if the animal is obstructing? Well, if the animal presents a deterioration and is getting agitated, you may try sedation. But just remember, we will see later, sedation may just delay the problem, not treat it. If the animal is acutely obstructing, you want to intubate it before it crashes. So probably intubate with propofol and then keep it sedated, anesthetize a tiny bit, and half an hour, 40 minutes, and then reattempt extubation. If the second extubation fails, I would say the animal is not a good candidate to maintain the airway spontaneously. So you probably need to consider a tracheostomy in this animal. You may identify animal that's more likely to need a tracheostomy, and those are the ones with severe upper airway disease, and that during surgery develop severe swelling, they got a very small trachea, or they are very obese. The thing we need to remember, that's my personal judgment, so don't quote me on this one. We are doing everything selecting this animal to elongate the nose, but my opinion is this animal, they don't need necessarily a longer nose, they need a better nose. And sometimes they get longer noses, but they're bad inside, so that you don't get a real benefit. But anyway, having a longer nose actually helps a tiny bit after corrective surgery, regardless. So it's not a bad thing. In terms of postoperative sedation, this is indicated in animals that are getting agitated, they start making respiratory noises, and the sedation will decrease the stress and the peak flow. If there is less flow, the animal needs less pressure to drive flow, and that means less work of breathing. This is indicated in stress doc after thoracolapharyngea surgery. You need to use the drug to minimize the risk of airway obstruction. Again, my top one is dexmedetomidine. I would be very careful with drugs like acetaminophen or opioids because they can actually cause loss of the airways and aspiration. If you use a dexmedetomidine, intend to infuse 0.5 to 1.5 microgram per kilo per hour, and you need to monitor oxygen saturation, provide oxygen flow by to this animal, and always monitor for obstruction. As I told you before, I see many of these cases, they start struggling, you put them in sedation, they get slightly better, and then this is a double-edged sword, as it is in the picture, because the sedation, this animal will obstruct eventually. You just delay the obstruction, and that usually happens at the end of the day or out of hours when there is less personnel, so it's worse. So if I have an animal that really has to obstruct because there is nothing to prevent it, I'd rather have the animal obstructing during working hours when we got full staffing and we can promptly intervene to intubate it and perform a tracheostomy. The last thing I want, animal obstructing at night, 10 o'clock at night, we reduce staffing level. You can use these decongestants and vasoconstrictors to try to improve the airways. The two reported one is adrenaline nebulization. Usually uses 50 microgram per kilo in 5 milliliters of saline. You can use it up every 2-4 hours. Better using a mesh nebulizer because it makes smaller particles so they can travel better. Efficacy still to be fully demonstrated. There are quite a few case series about it and case reports, but there is not really a good prospective study. It's also because it's very difficult to assess the efficacy of airway resistance in a non-intubated animal objectively. You would need whole body plethysmography in an animal before and after adrenaline to see the effect. One thing I've been told is just to protect the eyes when you're giving adrenaline, because if it gets nebulized in the cornea, it may cause the vasoconstriction that may result in ulcer. So put an eye ointment, possibly a carbomer or Vaseline-based eye ointment, so a lanolin-based eye ointment, so quite thick, that's going to prevent the adrenaline to go into the eye and don't direct the flow to the eye. Other vasoconstrictor use is silometazoline or oxymetazoline. Be careful because while you can do adrenaline nebulization, it's very well tolerated in a awake animal. Silos and oxymetazoline, use them only in an anesthetized animal. If you ever made the mistake to spray your nose when it's really inflamed inside with oxymetazoline or silometazoline, it causes excruciating sharp pain. I've done that once accidentally because I forgot during anesthesia. I thought I'd do in recovery before the animal wake up, and as soon as they put the oxymetazoline, the animal starts screaming in pain and pulling for the nose, and I got really bad recovery to resedate the animal. So you even got the wound open if they had surgery. So this is really causing sharp pain, excruciating pain for a short amount of time, which you don't really want. Do it while under anesthesia and let them about 10-15 minutes before waking them up. So you do it at the end of surgery. Steroids and oral steroids. Well, you want an anti-inflammatory on board in this animal for pain control and control of soft tissue edema. Now, if you talk a mere efficacy in terms of controlling edema and inflammation, steroids are better than non-steroidal. And it's very common to give 0.3 mg per kilo dexamethasone just before or after induction of anesthesia, simply because it's the most powerful anti-edematous drug that we got around compared to non-steroidal. There is an argument, does it make worse GI complication? Well, still to be demonstrated. These animals got so many risk factors that it's difficult to assess. Non-steroidal, they are less effective on edema, probably more effective on pain, and better tolerated, I'm not sure. So probably most of these animals, when they're bad, they will get a steroid at least once, that they may require for a couple of days post-operatively to control the edema. And another drug you can use as an analgesic, though it's not is non-opioid, which is good, but it's not a true anti-inflammatory, is paracetamol in dogs. You can use paracetamol to try to help control post-operative pain. If you do brachycephaly surgery, you can do maxillary block. If you do the tieback, you can do local infiltration, a splash of anesthetic before closing, to reduce the post-operative pain and minimize or completely remove the need for opioids. Other drugs you need to consider. Well, consider the comorbidities. And this is particularly relevant for brachycephalic. These animals are prone to reflux and regurgitation. A significant amount of them, a proportion of them will have a hiatal hernia, which is increasing the risk of reflux and aspiration. So it's very common to require antacid, anti-nausea, metoclopramide. So this animal we get, at least where I work, where I've been working, maropitant as an anti-nausea agent. It actually does help as a tiny bit analgesic as well, working on your urcanin-1 receptor. Omeprazole, 1 mg per kilo, which is demonstrated an effect on gastric pH. So is increasing the pH of the reflux if it happens. And metoclopramide, 1 mg per kilo per 24 hours. Now, this is less evidence about metoclopramide, and some people try even to push your 1 mg per kilo per hour to see the effect. In experimental animals, you can see some effect at very high doses, but there is no study that I'm aware of that's demonstrating a beneficial effect, a dramatic beneficial effect of a high doses in brachycephalic breeds. And if you use high doses, 1 mg per kilo per hour for 2-3 hours, you actually risk to cause extrapyramidal signs in the animal recovery, which worsen quality of recovery, and you may need to sedate it, which is really something you don't want. So we tend to stick with a low dose, 1 mg per kilo for 24 hours, and it's continuing post-operatively for 1 to 2 days until you get metoclopramide PROS. Finally, oxygen therapy. Well, if you use a nasal oxygen with mask, you can achieve up to 30% oxygen concentration, or even if you use a cannula. If you use high flow nasal oxygen, if the animal tolerates it, you can achieve up to 100% oxygen with some positive end expiratory pressure, which is brilliant because it's splinting the airways. The problem with high flow nasal oxygen is you need 1 liter per kilo per minute. These machines are draining oxygen like there is not tomorrow. So if you got a 20-kilo dog, that means you're going to have 20 liters per minute of oxygen. So every minute you use 20 liters of oxygen. Yeah, unless you got a very large oxygen generator plant sitting outside your hospital, or liquid oxygen in a big tank, if you use cylinders, even big cylinder like J size, you're going to run out of oxygen very, very quickly. So you need to balance the two. If you give oxygen, remember that humidification prevents cooling and drying of the mucosa, protecting it. In some cases, has been reported, the use of non-invasive ventilation with a CPAP helmet. You see a picture there. This is not a brachy breed, it's an animal with pneumonia. Has been reported to be beneficial just because the positive pressure tends to split the airways and keep the airway. There was a nice study they did in animals, in dogs, CT, using the CPAP, and demonstrated there was a splinting effect on the oropharyngeal airways. So the air pressure tends to push the tissue, possibly may even reduce edema, because edema is a balance between hydrostatic and airway pressure. So you also achieve increased FiO2. Will all animals tolerate it? No, most of them actually don't do that bad. The noise is the major issue because this high flow of oxygen is quite noisy. There is a Venturi injection. If we want to save oxygen, use a lower concentration, and that's noisy as well. So you might need to sedate this animal. And the noise may depend on the device, the location, sorry, on the arrow. No, you can't see my arrow. The location on the port, that you can see that in yellow when he's injecting oxygen. So if he's very close to the ear of the dog, he may make this hissing noise very loud that can bother the dog. I finished my presentation. That's the picture on the right, actually, is very cute. It's a dog that had last week brachycephaly surgery. And we believe as soon as he was out, he starts sniffing like he's never done before. We actually probably believe that for the first time in his life, this dog can smell properly because he actually has got nostrils and he had the redundant turbine removed. So the smell could actually read the crib plate and the brain. So it was very, very cute. It was smelling flowers everywhere in the garden. Thank you very much. And then we're going to see, I think there are a few questions.
Okay, thank you for Professor Federico's wonderful talk. Now we are moving to the Q&A session. If you have any questions, please ask them through the Q&A function. Now, next, also let me showcase our flagship product, the veterinary anesthesia one-stop solution, as shown in the screen. It's a bestseller in over 130 countries and regions worldwide. And please take a look at the screen if you want to learn more about our veterinary anesthesia one-stop solution. You can visit our official website for further product details. Okay, if you can type at the Q&A function if you have any question.
So I got 3 questions here that I found, 2 in the chat. So the first question was about the urinary catheter. So essentially, unfortunately, I don't have it here with me, and it would take me a few minutes to get it. But what I do, so you got your endotracheal tube. I put a rigid dog urinary catheter inside the endotracheal tube, so that the tip of the urinary catheter sticks out like 5 centimeters. So I go for normal intubation with laryngoscope. When I see the laryngeal opening, even if it is really, really small, just a tiny bit, I advance the urinary catheter inside the larynx and the trachea. If you're not sure, you can even connect a capnograph to the urinary catheter, so you can see if you're in the trachea or the esophagus, because you will have CO2 if you're in the trachea. Once I sure in the trachea, I essentially hold the catheter in place and advance the tube with gentle movement or rotation to try to push it to open the arytenoid if there is a mass of edema, to gentle push it on the side and try to enter inside the larynx and the trachea. The other question was about tilting the operating table to avoid dysphagia. I assume it means regurgitation, reflux regurgitation, because these animals they're intubated and anesthetized, so they shouldn't be dysphagic there. But yes, even when you do the airway surgery, you tend anyway to have the head higher than the rest of the body on a slight inclination, like 5-10 degrees Trendelenburg position, so anti-Trendelenburg position, so that you got better visualization, surgical visualization of the airways. Of course, if you feed them afterwards, sometimes postural feeding can actually help if they got hiatal hernia or megaesophagus. Other questions that we got, do you have any suggestion to an alternative of dexmedetomidine and butorphanol for sedation? Well, the alternative would be medetomidine. Xylazine, I never tried in this animal. The problem with xylazine tend to have a more effect on the airways and depression. So my second choice would be medetomidine. So I don't know what the person who asked what Nadia has available, but it would be medetomidine my second choice. And if there is not butorphanol, you can use any other opioid that you may use. If you increase the dose of medetomidine, you can actually sedate the animal just along with the alpha-2 agonist enough. If you don't have medetomidine, then there would be xylazine, but I don't have experience. I would probably try to go with the lowish dose of xylazine to limit the respiratory cardiovascular effect. So got another question from Sonia Huang. Just want to ask that we have 11 brachycephalic dogs recover from anesthesia with tachypnea. So they we use buprenorphine, dexmedetomidine for boas to perform a cylinder block with analgesia before recovery. We make sure that the patient are not hypothermic and hypercapnic, but once in a while we assist the patient start panting. Yes, actually that's fairly common. Actually, I see, unless they're quite sedated, and I suspect some of it, especially if they pant beforehand, is a kind of a driver of the respiratory center, because sometimes I've seen hypothermic, hypercapnic animal, the eukaryotic hypothermia, eukaryotic hypocapnia, but they still pant. And I suspect you got the respiratory center that a bit enter this vicious circle of panting, and it's quite difficult to get them out of it. I assume buprenorphine can also make them pant, because any opioid can actually cause panting in dog when they're awake. It will cause hyperventilation under anesthesia and panting when they're awake. So that could be another possibility. But yes, it does happen. Usually the solution is to sedate a bit more. Yes. What you can try to decrease the swelling as well, you can use nebulization of adrenaline or a vasoconstrictor in the nostril. But the only way to stop the panting realistically is actually to give more dexmedetomidine slowly until they stop panting. Dexmedetomidine will not cause ventilatory depression, but it might stop panting them. But sometimes they got this drive that's essentially trigger, and it's very difficult to stop it. I don't know if somebody else has got any question. I don't know if there is another one there.
Hi, Dr. Federico. There also have 2 questions in the chat bar. You can check.
The chat is the one that I think already is the one about. Hang on a second. I already answered those 2. The one on the urinary catheter and the one on the table. I already answered those 2 before. Yes.
Okay. So, is there anybody still have any question?
I mean, if you got any question at some point, my email was on the first slides. I think there is a recording, so you can always get in touch with me and for any specific question. I'm all happy to answer them.
Okay, thanks again to Dr. Federico. And this brings our today's end of the webinar. And please remember to follow up our social media accounts as shown in the screen. And you can watch the replay within 1 week. And also we will announce the next academic on it. Okay, thank you again and have a nice day.
Thank you very much, everybody. Thank you.
Okay, have a nice day. Bye.
Bye-bye.